Hi everyone, myself Bhaktesh. Today I will be discussing one of the easiest topic in pathology, that is normocytic anemia. Before jumping into the topic of normocytic anemia, let us first see about introduction and overview of normocytic anemia. Normocytic anemia is a condition in which the size and shape of the RBCs is normal, but the number of RBCs in the blood is decreased. Even the hematocrit value and also the hemoglobin content in the body is decreased. Based on the number of reticulocytes in the body, there are two conditions: high reticulocyte count and now low or normal reticulocyte count. The high reticulocyte count is due to hemolysis and acute blood loss. The low or normal reticulocyte count is due to decreased production of RBCs. Under high reticulocyte count, we have hemolysis. Under hemolysis, there are two kinds of hemolysis: intrinsic or intravascular hemolysis and extrinsic or extravascular hemolysis. In intrinsic or intravascular hemolysis, there comes membrane defects, enzyme deficiency, hemoglobinopathies, and under extravascular hemolysis there comes autoimmune conditions, mechanical conditions, infections, chemical or toxic substances. And under acute blood loss we have three main conditions, that is trauma, GI bleeding and surgical blood loss. On the other side, there is a low or normal reticulocyte count, which is due to decreased production of the two main conditions leading to decreased production of RBCs is marrow disorders and systemic conditions. The marrow disorders include aplastic anemia, pure red cell aplasia, and marrow infiltration. And the systemic conditions leading to decreased production of RBCs are anemia of chronic disease, chronic renal failure, endocrine disorders, and nutrient deficiency. Now we will discuss about the conditions leading to intrinsic or intravascular hemolysis. First, there will be membrane defects leading to intravascular hemolysis. Then there will be enzyme deficiencies and hemoglobinopathies leading to intravascular hemolysis. Under membrane defects, first we will see about hereditary spherocytosis. Then we will see about hereditary elliptocytosis. Then we will see about paroxysmal nocturnal hemoglobinuria. Let us first discuss about hereditary spherocytosis. Hereditary spherocytosis is a genetic disorder of the RBC membrane protein deficit leading to characteristic spherocytes. It is an autosomal dominant or recessive inheritance. The hereditary spherocytosis is due to mutation in genes coding for membrane proteins. If we look for the pathogenesis of hereditary spherocytosis, there are few proteins present on the RBC membrane like angrin 1, band 3 and spectrin, and there are also few lipid molecules. All these molecules and proteins, they interact with each other in a horizontal fashion. What happens in hereditary spherocytosis is there is a decreased horizontal interactions between this angrin 1, band 3 and spectrin and lipid molecules. This leads to membrane instability, loss of membrane surface area, and there is a change in cell shape. If we see the morphology of a red blood cell in this hereditary spherocytosis, the RBCs are spheroidal, they are small, they are hyperchromic, and they lack central pallor. And if we discuss about a pathophysiology cycle in this hereditary spherocytosis, first there is a defective RBC membrane, then there is a formation of spherocyte, then there is increased rigidity and reduced deformability, and then there is a entrapment and destruction in the spleen that leads to extravascular hemolysis that ultimately leads to anemia and increased bilirubin in the body. If we see the clinical symptoms in which the patient comes to hospital, there is a hemolytic anemia characterized by fatigue and pallor. Then there is jaundice characterized by icterus and yellow eyes. Then there is a splenomegaly characterized by enlarged spleen. Then there are gallstones formation characterized by pigment stones in gallbladder. Then there is a rare condition of aplastic crisis. If you want to diagnose this hereditary spherocytosis, first we will do history and physical examination. Then we will do complete blood count, in which there is a decreased hemoglobin, increased MCHC, increased RDW, and high reticulocytes. And if you do the peripheral blood smear, there are formation of multiple spirocytes. And when we do the osmotic fragility test, there is increased lysis in hypotonic solution. And when we do EMA binding test, there is a reduced use in 5-malonamide binding. And at last, when we do SDS page test, no, there is it detects specific protein deficiencies. This is all about hereditary spherocytosis. Then we will discuss about another membrane defect which is leading to intravascular hemolysis, that is hereditary elliptocytosis. Hereditary elliptocytosis is a condition in which there is an inherited red blood cell membrane disorder characterized by abnormally shaped elliptic erythrocytes, that is oval erythrocytes, making them fragile and prone to premature destruction. If we see the morphology of the RBC in hereditary elliptocytosis, the RBCs are elliptical, that is, they are oval and they are fixed in shape. They cannot change their shape. In what happens in normal RBCs is they can change their shape while traveling through spleen or traveling through blood. But in hereditary elliptocytosis, the RBCs cannot change their shape. If we discuss the genetic and inheritance of this condition, it is autosomal dominant and sometimes rarely it is autosomal recessive as well. And if we see the major affected genes in hereditary elliptocytosis, the genes are SPTA1, SPTB, EPB41, and other genes like SLC4A1, GYPC. And the pathophysiology of a hereditary elliptocytosis is similar to that of a hereditary spherocytosis. In this condition, there is a reduced horizontal interaction between the proteins present on the RBC membrane that ultimately leads to defects in spectrin tetramer formation and defect in spectrin actin protein 4.1 complex. If we see the clinical symptoms in the patient, most of the time they are asymptomatic, but there is a presence of fatigue, shortness of breath, and there is also presence of jaundice characterized by yellowing of skin and eyes. There is a splenomegaly characterized by enlarged spleen. There is a cholelithiasis characterized by gallstones, and there is also leg ulcers, which is very rare. And if we see the diagnosis and laboratory findings, and in peripheral blood smear, there is a presence of ovulocytes, there is a presence of pencil cells, and there is a presence of more than 25% are elliptocytes. And if we do the complete blood count, there is a low hemoglobin, high reticulocyte count, and increased RDW. There are some other tests like osmotic fragility, which is increased, using 5-malonamide EMA binding test, which is reduced, and genetic testing we will do for confirmation. There are many subtypes of hereditary elliptocytosis like common hereditary elliptocytosis, hereditary pyropoikilocytosis, spirocytic elliptocytosis, Southeast Asian ovulocytosis. And if you want to manage this hereditary elliptocytosis condition, in most cases there is no treatment, but we can give supportive care like folic acid supplements. In severe cases, we can give blood transfusions and we can do splenectomy. This is all about hereditary elliptocytosis. Now we will move on to another membrane defect leading to intravascular hemolysis, that is paroxysmal nocturnal hemoglobinuria. This paroxysmal nocturnal hemoglobinuria is characterized by chronic intravascular hemolysis, thrombosis, and bone marrow failure. If we see the pathophysiology of this PNH, there is a mutation in a PIGA gene which leads to deficiency of GPI anchored proteins in hematopoietic stem cells, which leads to deformity in RBCs, and those deformed RBCs are called affected PNH RBCs, which they ultimately undergo hemolysis and leads to formation of anemia. And if we look into clinical symptoms in the patient, there is a presence of fatigue or weakness, there is a presence of dark urine, that is a formation of hemoglobinuria. There is abdominal pain, there is dyspnea, there is chest pain, there is dysphagia, and there is erectile dysfunction in males. And if you want to diagnose this PNH, first we will do flow cytometry. This is a gold standard test. Then we will do lactate dehydrogenase test. Then we will go for reticulocyte count. And if we want to treat this paroxysmal nocturnal hemoglobinuria, first we will give complement inhibitors to the patient like eculizumab and ravulizumab. And then we, in severe cases, we will do bone marrow transplant, and we can also give supportive care like anticoagulants and blood transfusions. This is all about membrane defects leading to intravascular hemolysis. Now we will go for enzyme deficiencies which are leading to intravascular hemolysis. First we will discuss about G6PD enzyme deficiency, that is formation of Hench bodies. Then we will discuss about pyruvate kinase deficiency. First we will go for G6PD deficiency. In what happens in G6PD deficiency is and there is a formation of Hench body in this deficiency. In a normal RBCs, there is a normal functioning of G6PD enzyme, that is glucose 6 phosphate dehydrogenase enzyme. There is a normal functioning of that, due to which it removes reactive oxygen species, leading to protection and formation of hemoglobin. In case of G6PD enzyme deficiency, there is no removal of reactant oxygen species, that leads to hemoglobin oxidation and denaturation. Since there is a hemoglobin oxidation and denaturation, the hemoglobin get precipitated. The precipitated hemoglobin is known as Hench bodies. And when we do the blood smear of this G6PD deficient blood, there are presence of Hench bodies in the smear. The formation of Hench bodies is the key characteristics of this glucose 6 phosphate dehydrogenase deficiency. Now we will go for pyruvate kinase deficiency. Pyruvate kinase deficiency is a condition. It is rare, it is genetic, it is lifelong disorder causing premature destruction of red blood cells. It is most common in glycolytic enzyme defect. It is autosomal recessive in nature, and the estimated prevalence is 1 in 20,000 to 3 lakh people. If we discuss the pathophysiology of this pyruvate kinase deficiency, what happens in normal glycolysis is glucose gets converted into pyruvate, and in the process there is a formation of ATP. We know that. For that we need pyruvate kinase. That is also we know. But in case of a pyruvate kinase deficiency, since there is a deficiency of pyruvate kinase, glucose does not lead to formation of pyruvate, or there is a reduced formation of pyruvate, and also there is a reduced ATP. Since there is a reduced ATP, it leads to membrane instability, and since there is a reduced pyruvate and ATP, there is a condition called as chronic non-spherocytic hemolytic anemia, which is caused due to splenic sequestration and hemolysis. When we look out for the clinical symptoms in the patient, we see it slightly different in neonates and in adults. In neonates, there is a jaundice, there is severe anemia, and there is a exchange transfusion. And in adults, there is a fatigue, low energy, shortness of breath, rapid heartbeat, pale skin, jaundice, gallstones, splenomegaly, dark urine, and iron overload. And if you want to do diagnosis and testing of this pyruvate kinase deficiency, first there is a clinical suspicion that there is unexplained hemolytic anemia. Then we will do initial tests like a complete blood test, and we will do reticulocyte count, which is obviously increased. Then we will do peripheral blood smear, in which we will see about polychromasia, some Burr cells, but there will be no spherocytes. And for confirmation, we should have to see for increased bilirubin and low haptoglobin and high lactate dehydrogenase. And for the specific tests which are done for pyruvate kinase are pyruvate kinase enzyme activity test and a PKLR gene molecular test. And if you want to manage and treat this condition, we can give supportive care like red blood cell transfusion, folic acid supplementation. And if you want to treat this one, we can give iron chelation therapy, cholecystectomy, and exchange transfusions. And we can also do surgical interventions like splenectomy. And there are also upcoming emerging therapies to treat this condition like mita pivot and gene therapy. This is all about pyruvate kinase deficiency and the enzyme deficiency leading to intravascular hemolysis. Now we will move on to hemoglobinopathies. There are three major hemoglobinopathies leading to intravascular hemolysis. The first one is sickle cell anemia. Then there is thalassemia. Then there is hemoglobin C disease. First we will look for sickle cell anemia. Then we will discuss about thalassemia. Then we will discuss about hemoglobin C disease. We all know sickle cell anemia. It is an inherited blood disorder affecting red blood cells with abnormal hemoglobin S production. In this case, the normal RBC shape changes to sickle cell shape due to the production of abnormal hemoglobin. The key characteristics of this sickle cell anemia are the RBCs are rigid, the RBCs are sticky sickle cells, there is a blood flow blockage, there is a vaso-occlusive crisis, severe pain, organ damage, anemia, chronic pain, fatigue, and delayed growth. If we say thalassemia, it is a genetic disorder. It is a genetic disorder causing reduced production of hemoglobin chains, either alpha chain or either beta chain. If the reduction is in alpha chain, it's alpha thalassemia. If the reduction is in beta chain, it's beta thalassemia. If we look out for key characteristics, there is a microcytic anemia and ineffective RBC formation. And there are a few common characteristics like fatigue, pale skin, splenomegaly, bone deformities, and iron overload. In case of hemoglobin C disease, it is an inherited blood disorder with abnormal C hemoglobin. मतलब in this there is a production of hemoglobin C instead of hemoglobin A or hemoglobin B. And when we see about morphology of RBC in hemoglobin C disease, the normal RBCs get converted into target cells. The key characteristics generally are milder than sickle cell anemia and beta thalassemia major, but the RBCs are very fragile. The conditions are often asymptomatic. There is a presence of mild chronic anemia, and there is an enlarged spleen, and there is a possibility of mild jaundice and fatigue. This is all about hemoglobinopathies, which is leading to intravascular hemolysis. Now we will discuss about extravascular hemolysis. The conditions leading to extravascular hemolysis are autoimmune conditions, mechanical conditions, infections, and chemical or toxic substances. We will mainly discuss about autoimmune condition, mechanical conditions, and chemical or toxic substances. In case of infections, we all know. In diseases like malaria, babesiosis, there is a formation of plasmodium and all, and that ultimately leads to hemolysis and leads to anemia. So we will only discuss about autoimmune, mechanical, and chemical or toxic substances. First, we will see about autoimmune conditions. The autoimmune causes of extravascular hemolysis, there are two types. First, we will discuss about a warm autoimmune hemolytic anemia and a cold autoimmune hemolytic anemia. In warm autoimmune hemolytic anemia, the optimal temperature is 37 degrees Celsius. In this condition, what happens is there is a RBC. The RBCs are bound by IgG autoantibody, and this whole complex is get eaten by macrophages present in the spleen. Okay, and in what happens in cold autoimmune hemolytic anemia is there is a RBC. The RBCs are surrounded by IgM autoantibody, and the whole complex is eaten by macrophages present in the livers. So ultimately that leads to destructions of RBCs. There is hemolysis that ultimately leads to anemia. That is all about autoimmune causes of extravascular hemolysis. Then we will see about mechanical causes of extravascular hemolysis. The mechanical causes of extravascular hemolysis include the altered red pulp microenvironment in spleen that ultimately leads to enlarged spleen, that is splenomegaly, and there is a pathologic RBC inclusions like Henge bodies, and there is a formation of, we also know about Hoel gel bodies, and we also know about plasmodium formation in case of malaria disease. Those all leads to hemolysis. Then we also know about acquired mechanical rigidity, in which the RBCs become rigid and the RBCs are not flexible, that leads to microangiopathic fragments. And we also know about inherited red cell membrane defects like spherocytosis, elliptocytosis, that those conditions also lead to hemolysis that ultimately leads to anemia. Now we will discuss about the chemical and toxic causes of extravascular hemolysis. First, we will see about what are the chemical substances causing extravascular hemolysis. The chemical substances are primaquine, sulfonamides, dapsone, naphthalene, and nitrofurantoin. These chemical substances, what they do is they leads to deficiency of a glucose 6 phosphate dehydrogenase enzyme that ultimately leads to hemolysis and anemia. In case of toxic substances like lead, copper, and arsenic, what they do is they change the shape of RBCs into target cells, and the target cells get converted into echinocytes. The echinocytes undergo hemolysis and leads to anemia. And if we see the key features of extravascular hemolysis, there is a jaundice, obviously, and there is a splenomegaly, there is anemia, there is reticulocytosis, but there is no hemoglobinuria. That is, we should have to remember. Now we will see about acute blood loss conditions leading to hemolysis. Under that, we will see about trauma, then we will see about GI bleeding, then we will see about surgical blood loss. Before discussing about the condition of acute blood loss, let us first understand about a pathophysiology behind the hemorrhagic shock. We all know, we all studied in physiology about this pathophysiology about hemorrhagic shock. But let us recap that one. What happens is there is a decreased blood volume that leads to decreased venous return, that leads to reduced cardiac output and reduced tissue perfusion, that leads to cellular hypoxia and anaerobic metabolism, that leads to organ dysfunction, that leads to other compensatory mechanism, but then again that leads to reduced blood volume. Now we will see about causes of acute blood loss. First we will see about trauma, then we will see about GI bleeding, then we will see about surgical blood loss. In case of trauma, there are two kinds of trauma. That is, there is a blunt trauma and there is a penetrating trauma. In a blunt trauma, it is like in accidents of car crash or falling from a very tall building. Those are example of blunt trauma. In case of penetrating trauma, for example, stabbing, gunshot, pricking, those are the examples for trauma related penetrating trauma examples. What happens in blunt trauma is there is a damage to internal organs, and there is also internal rupture. And what happens in penetrating trauma is there is a vascular laceration and major vessels disruptions that leads to hemolysis, that leads to acute blood loss and hemolysis. And if we discuss about GI bleedings, there are two types of GI bleeding. Okay, first is a upper GI bleeding, and then there is a lower GI bleeding. Why it is like that? Upper GI bleeding and lower GI bleeding, based upon the ligament of threads, we divide into upper GI bleeding and lower GI bleeding. Those causes which are present above ligament of threads, we classify it into upper GI bleeding causes, and those causes which are present below the ligament of threads, we classify into causes of lower GI bleeding. First we will see about causes of upper GI bleeding. The causes are peptic ulcer disease, esophageal varices, malarious tear, gastritis, and malignancy. And when we see about lower GI bleeding causes, there is a diverticulosis, angioidosplasis, cellitis, polyps, and malignancy. This is about GI bleeding leading to acute blood loss. Now we will see about surgical blood loss. In surgical blood loss, there are two types. That is during surgery, and there is another one is after surgery. During surgery is intraoperative. After surgery is postoperative. In intraoperative surgical blood loss may be during orthopedic surgery, liver surgery, or maybe there may be some patient factors leading to blood loss. And in case of a post-operative, that's after surgery blood loss, like wound hemorrhage, coagulopathy, or anastomotic leak. Those are the examples of after surgery blood loss. This is all about acute blood loss. And then we will see, now we will see about assessment and management of this acute blood loss. If you want to assess and manage this acute blood loss, first we will do initial assessment, like we will check about vital signs, mental status, lactate and base deficit. Then we will go for immediate resuscitation, like IVSS, crystalloids, blood products, massive transfusion protocol. Then we will go for definitive hemostasis, like damage control surgery, endoscopy, interventional radiology. Then we will go for monitoring and support, like ICU, organ support, and coagulation monitoring. This is all about acute blood loss. Now we will see about low reticulocyte count leading to normocytic anemia. As of now, we discuss about high reticulocyte count condition leading to normocytic anemia. Now we will discuss about a condition of a low reticulocyte or normal reticulocyte count leading to normocytic anemia. Under that, we will discuss about marrow disorders and systemic conditions. In marrow disorders, we will see aplastic anemia, pure red cell aplasia, and marrow infiltration. And in systemic conditions, we will see about anemia of chronic disease, chronic renal failure, endocrine disorders, and nutrient deficiency. In case of marrow disorders, as of now we saw that aplastic anemia like pancytopenia, hypocellular marrow, or fat replacement, or in case of a pure red cell aplasia there is a selective erythroid hypoplasia, and in case of marrow infiltration there is a myelocytic anemia, like for example leukemia, metastatic cancer, and myelofibrosis. What happens in bone marrow failure is there are three conditions leading to bone marrow failure. First, there is a pure red cell aplasia, aplastic anemia, and myelophthisis, that is a marrow infiltration. In bone marrow failure, there is an underproduction of RBCs or reticulocytes. The causes of pure red cell aplasia is idiopathic. It may be idiopathic or B bugs or radiation or viruses like hepatitis, EBV or IBV, or the conditions like Fanconi anemia. And in case of aplastic anemia, the conditions are almost same, like idiopathic, B bugs, myelofibrosis, viruses like hepatitis, EBV or IBV, and conditions like Fanconi anemia. And in case of a marrow infiltration, the causes are metastatic cancer like a breast cancer, prostate cancer, lung cancer, or a myelofibrosis, or a granulomatous disease, or Gaucher's disease. These are the causes leading to bone marrow failure that ultimately leads to underproduction of RBCs. Now we will go for systemic conditions leading to normocytic anemia. First, we will see about anemia of chronic disease, chronic renal failure, endocrine disorders, and nutrient deficiency. First, we will see about nutrient deficiency. If there are no building blocks for production of RBCs, obviously the RBCs formed are not good or they are not proper. The main requirements for RBC formation is iron and vitamin B12 and folate. If there is deficiency of iron, that leads to iron deficiency anemia, in which there will be microcytic cells and there is a low serum iron and there is a high TIBC. And in case of vitamin B12 deficiency, that leads to megaloblastic anemia, for example pernicious anemia. In this case there are microcytic cells, hypersegmented neutrophils, and neurological symptoms. And in case of folate deficiency, it leads to megaloblastic anemia. In this case there are microcytic cells and dietary causes. And when we see about hormonal causes leading to systemic conditions, there is a decreased erythropoietin production that ultimately leads to chronic kidney disease. And when we see about ineffective erythropoiesis, the bone marrow is working, but it's not working properly. In that case, there are some conditions like myelodysplastic syndrome and sideroblastic anemia. In a myelodysplastic syndrome, what happens is the precursor cells are abnormal and they die in the marrow only, they don't come into the blood. And in sideroblastic anemia, the iron gets accumulated in mitochondria. Since the iron gets accumulated in the mitochondria, the heme will not be produced. Since the heme is not produced, the proper RBC is not formed. And if we see about the bone marrow failure and separations, we all see that we saw in early slides, like aplastic anemia causes, pure red cell aplasia causes, and bone marrow infiltration causes. We have to remember one point here. The key diagnostic principle is if there is a low reticulocyte count, that indicates that there is an inappropriate bone marrow response to the anemia. That one you should have to remember. This is all about normocytic anemia. We will have a summary about what all we discussed in this video. First, we saw about introduction to normocytic anemia. What is it about? Then we saw about reticulocyte count, what happens in high reticulocyte count, and what happens in low reticulocyte count. And in high reticulocyte count, we saw about hemolysis and acute blood loss. In hemolysis, we saw about intravascular and extravascular hemolysis conditions, and in acute blood loss, we saw about trauma, GI bleeding, and surgical blood loss. And in a low reticulocyte count condition, we saw about systemic conditions leading to normocytic anemia, and also we saw about marrow disorders leading to normocytic anemia. This is all about normocytic anemia. Thank you for your time, and thank you for your attention. Thank you.